πρόσκληση και ιδιαίτερα τον πρόεδρο, τον καθηγητή, τον κύριο Αναστασιάδη. You can see my presentation, no? Okay. I'll present in English in case that someone from the audience does not speak Greek. Preeclampsia is an enigmatic disorder that is labeled as a disease of theories. I do not have any financial disorders. And in this presentation, we'll deal with the definition, incidence and etiology, clinical manifestation management, prevention, and what do we have to do in the future. From 2013, preeclampsia is not only the proteinuria plus the arterial pressure, but it's also the involvement of other systems as increase of platelets, serum creatinine, liver enzymes, pulmonary edema, cerebral and optical systems, but also the offspring, that it's the uteroplacenta ischemia, the placenta ischemia, and what this causes to the pregnancy. That means intrauterine growth retardation, including the Doppler waveforms. And this is exactly the same in the definition of the different associations as the American College of Obstetric Gynecology, the International Society of Pregnancy, the Canadian one, etc. This is the normal distribution in pregnancy. Here we see the gestational age and the normal distribution of the systolic pressure and the diastolic pressure. And the possible etiologic explanations, like is the sleep disorders, diabetes, maternal obesity, diabetes and maternal obesity, maternal intestinal dysbiosis, SARS, it was said before, periodontal disease, and uteroplacental ischemia. And here is a manifestation, experimental evidence about the uterine ischemia. And here we see that if they clamp the renal artery, we have hypertension in a non-pregnant rat. If they clamp the aorta in a non-pregnant rat, we have again no hypertension. In a pregnant rat, this clamping is causing hypertension. And at this rat, if we make a hysterectomy, we have no hypertension. So the ischemia is causing hypertension. But also there are other explanations, and we see here in these pregnant rats that they were transplanted with gut microbia from normotensive pregnant women. You see, this is the blood, the blue rat, and with the ones that with the preeclampsia from preeclampsia patients, the brown one, and we can see that the rat is performing preeclampsia. So preeclampsia is not a disease. We can call it a syndrome. We have arterial pressure. We have symptoms like from central nervous system, from the gut, from hematological disorders. We can have also fibrinolysis and hemolysis that will call HELP, disaster for the pregnancy, and also Capricorn loss that will cause face edema, proteinuria, and pulmonary edema. Again, when they are getting the rabbits and they are making a suture in the placenta, so they, let's say, got a part of the placenta, so they're presenting ischemia. We'll see that at the moment of the ischemia, again, we have hypertension. And this is probably the explanation that the spiral artery, that this is the normal spiral artery. We see here the myometrium and the endometrium. We can see how it is in normal pregnancy, that because the fetus needs blood, it's, let's say, destroying the spiral artery to have more blood. And we can see that in preeclampsia, this doesn't happen. And this causes oxidative oxidative reduction from the fetus, causing increasing inhibitin and leptin and decreasing PAPA and PP13. So preeclampsia is a three-stage disorder. The stage 1, that is deficient of the proangiogenic factors. Stage 2, from the placenta, as we just said, increasing the apoptosis, cytokines, and SFLT1. And then the stage 3 that causes preeclampsia. Let's go now to another very bad situation that we have, the postpartum hypertension. And again, the definition for the postpartum hypertension is only when we have only hypertension, or we have also other symptoms, hypertension plus proteinuria, or so we have postpartum preeclampsia and eclampsia. That's also life-threatening. And we can see here for the postpartum preeclampsia, the risk factors, that's cesarean delivery, intrapartum fluids, placental dysfunction, maternal risk factors, and also have different clinical manifestations. This is not only for the pregnant women. We know that the risk of developing hypertension with a history of hypertension during pregnancy is 6 times higher, even excluding the one with a chronic hypertension. And this is the reason why the American Cardiovascular, the American Heart Association, in their guidelines, they say that they have to be checked 8 to 12 weeks postpartum, and if everything is normal, also 1 to 2 years postpartum, because and after this every 1 year, because the risk of reporting hypertensive disorders, it's really high. So the angiogenic factors in preeclampsia, it's as I said before, increasing the antiangiogenesis 1 and decreasing the proangiogenesis 1. And the clinical presentation of this is the consequence of widespread endothelial dysfunction triggered by the excess of SFLT1. And when we screen, we have the maternal arterial pressure, the PLGF, and also we are measuring the uterine the blood, the Doppler one. And if the screen is low, less than 1 in 100, it's a routine platelet care. But if it's high, the probability of having hypertension during pregnancy, we know that when we administer aspirin 100 to 160 milligrams from early gestation before 16 weeks until 13 weeks, there is a possibility, as we'll see, of 70% reduction. But this is also in postpartum hypertension. The ratio, it was found that it's increased. So antepartum also is association with postpartum hypertension, and this means that it's useful not only for the hypertension during pregnancy, but also for the postpartum one. This is the ASPRE study that changed everything after 2017, that when we administer aspirin to these women that with increased probability of hypertension, we have a risk of preterm preeclampsia, decreased risk of 89%, and for all pregnancy, 62%. So it's something like 70% reduction. Unfortunately, we obstetricians, we don't remember, we forget that pregnant women must exercise at least 140 minutes per week. We can have this that we are using it in the first trimester to administer aspirin. The dietary calcium supplementation is crucial, and also in the time of birth that we can decrease the probability to 55%. Also, it's postpartum information for postnatal women. because when a woman goes at home with a baby, forgets everything. So we have the warning signs, especially the severe headaches. And what is the future? We must prospective the risk factors, the determination of the risk factors, in-depth understanding the etiology and pathophysiology. That's very difficult because it's not only one, there are several. Must have algorithms, and we have the assessing the future risk of maternal health. And I would like also to invite you to the DEEP Congress that will host in Thessaloniki, DEEP 2023, May 4 to 6. Thank you very much.
Ευχαριστούμε, κύριε Αθανασιάδη.